Thank you for the kind introduction. Can we move slides from here? Right? Okay. So I will talk about not only the update in GCC region, but little bit that how CDC gives us, the figures, facts and figures, and I will talk about that how we are doing in Tawam Hospital, how our GCC can be improved, how we can get 95 goal and can start now. So I think I can read it from far. So epidemiology in HIV, what are the objectives today? Is the epidemiology in HIV, CDC, GCC, update and goals of 95 CDC and GCC, GCC knowledge about HIV diagnosis and treatment, how COVID-19 pandemic caused a problem in HIV getting our goals, and pandemic affected the HIV treatment, yes or no. So 95 goals by United Nations. What it is actually. So we need to know what does it mean 95. In 2014, the United Nations Program of HIV/AIDS, that's called UN/AIDS, launched 95 targets. The aim was to diagnose 95% of all HIV positive individuals, provide antiretroviral therapy for 95% of the people diagnosed, and achieve viral suppression for 95% of those who are treated by 2030. Now the thing is, the viral suppression is different definition in different areas. For example, in Tawam, we have less than 20 copies. It is a viral suppression. In sub-Saharan Africa, there is less than 400 copies. So it's a different in different regions in the different parts of the world. So epidemiology, HIV remains a major global public health threat with 1 million HIV-related deaths. So just think how many deaths we have with probably other co-infections, opportunistic infections, and so forth, and 2 million new infections and over 1 million HIV-associated TB cases each year. So this is a major health problem here. However, population-based studies showed that mild decline in incidence, prevalence, and deaths in the countries in East and South and Southern Africa that have expanded antiretroviral treatment at the fastest rate in the world. So remember, these African countries, they get a very cheaper antiretrovirals. For example, they get a very cheaper medications that are generic. So I was reading literature that was showing that they will get probably around $60 per month. If you get it from here, it would be 5,000 dirhams, 7,000 dirhams per month. So compare with 60,000, or now they're further decreasing it to maybe $30 or $40 per month. So it's quite reasonable. And the other thing is they are giving most of the people free of cost. Now here, if you want to see this thing, that in Mozambique, the death related in red, and the blue is the how the goals should be achieved. So death related in Mozambique are kind of increasing because it is one of the countries that is deprived of getting antiretrovirals. So we have to keep in mind, we have suggestions from CDC. I mean, we have to try to follow these CDC guidelines and so forth. So there was a trial in Botswana that was sponsored by Howard University in USA. And in that project, it was started from 2013 to 2017. In that project, they got almost 15,000 patients. And then all identified HIV positive patients who were not on antiretrovirals were referred to treatment and tracked to determine the linkage of care, antiretroviral status, retention in the treatment, and viral suppression. of all an estimated around 15,000 patients living with HIV, residing in 15 interventions communities, and this trial identified around 13,000 to 328 positive HIV persons that made around 93% of the population. So this study started 10,700 of estimated patients living with HIV in their status, and it increased. They increased the consumption of antiretrovirals for 2,000 more people. That is approximately 20% of the patients. So this is a good achievement in 3 to 4 years of their work, and increase 25%, with the greatest increases occurring 37% in youth and 37% in men and 77% as youth. So this was a great trial which was published in 2019 in Howard University trial. So I wanted to share this with you guys. Again, a greater increase in antiretroviral therapy coverage was achieved among men 40% compared to women 29%, and of the 12,000 persons who had a viral load tests, around 11,687, 98%, remember 98% were virally suppressed. So this was a very good initiative and very good trial in which 98%, not even 95%, 98% were RNA suppressed. Now remember, the same thing I was telling you, sorry, go back. If you see here, this is less than 400 copies. Now people have 420, 200, so this is 400 copies. And there was overall 82% well-documented viral load suppression by the study end. So now the universal knowledge about 95 targets. So what is the universal knowledge? The knowledge of HIV positive status and antiretroviral coverage increased towards 95 targets with universal testing, linkage, interventions, and antiretroviral therapy. Remember, we as medical care professionals, we play a major role in providing the knowledge for treatment, testing, diagnosing, and what are the consequences if they are not getting treatment. The increase in HIV testing and antiretroviral use amongst men and youth are essential to reaching those targets. So reaching those targets by 2025, 2030 depends on all amongst the responsibilities on us, on our shoulders, and many more who are just attending via the virtual conference, or the others people's, family practitioners, urologists, gynecologists. It's not only the infectious disease physicians that, because there are probably more of family medicine people or internal medicine people or general practitioners than infectious disease people. Now, this is the same CDC Howard trial, which you can see 14,270 people were hired, and then knows the people who know that HIV positive status was 93%. At antiretroviral therapy, the people amongst those who knows was 93%, and then virally suppressed was around 98%. So this is also a CDC Howard initiative that we saw in this slide. Now coming back to our GCC 95 goals, there was an excellent article which was published here in Journal of Infection and Public Health in 2020. What they saw, they summarized the level of knowledge and attitude about HIV/AIDS in 7 Arabian Peninsula countries: Saudi Arabia, Oman, Kuwait, Qatar, Bahrain, Yemen, and United Arab Emirates. So they saw the awareness of HIV in all these countries. A systemic literature search was performed using combined keywords of 4 scientific database of peer-reviewed publications from January 2010 to June 2019. And what we found that 25 5 articles were included in the systematic review and 20 studies in the meta-analysis. The data was analyzed using random effect model due to heterogeneity between the studies. 17 studies reported on the level of knowledge, and overall knowledge of HIV/AIDS in this region was almost 74%, so not reaching up to 95%. With the 95% confidence interval and 66 to 82%. So it was, the p-value was less than 0.01, so it is significant. And the attitude was 53%, so the p-value is also less than 0.01%. Now, just if you subdivide them, for example, to Oman, Bahrain, in Oman, you can see the reported knowledge was higher, around 95%. And in Bahrain, the population has not very positive attitude in 22%, 22.5%. So, I think we all have a responsibility, as I said, to educate the people and let them know that how we can, these days I feel that we need to tell the people that HIV is not a kind of a disease that used to be like 20, 30 years ago. It might be if somebody got by transfusion or by sexually transmitted disease, vertical transmission or something, then it might be a chronic disease, for example, like diabetes, hypertension, or he has to take, there is a single pill regimen, so he might have to take a single pill, and then he might, get his to a normal life. So I think the education is a must here. So over here, we can see the medical doctors showed higher knowledge of 94%. And this is good for us. So we know actually, at least in our region, 94.1 with the confidence interval of 92.93%. And the positive attitude was observed in less people. So it's lacking a little bit of positive attitude. The positive attitude is like, how to welcome a patient, just to see what questions they have, how much queries they have. The problem with our country is, that why we don't rely the knowledge, or why we don't tell this thing like from general practitioner to internal medicine people to family medicine people, that if they tell something and it is quoted, like if they quote it to infectious disease, and if there is something difference in between those two statements, then they take it a little bit seriously, because these people are already anxious, and then the anxiety further increases, that if somebody is different statements, it would be really hard. So at the end of the day, all these people usually are referred to infectious disease people. I used to practice in US. So in US, many of the family practitioners, many of the internal medicine people, and many of the other people who are trained in HIV, they are practicing, or they are prescribing antiretrovirals. But here, of course, the infectious disease professions, apart from some parts, a few parts of the areas in which the other than infectious disease practitioners, they are prescribing. So if you go further, the conclusion, the overall knowledge about HIV/AIDS was found to be satisfactory, 75%, and half, 52.8 of those displayed a negative attitude. So what was the recommendation? As the regular training courses, as well as reviewing and re-informing HIV/AIDS prevention guidelines would be useful to update the knowledge and improvement and attitude in this region. So whatever we are doing now, we are doing efforts now to, I think in the coming sessions, we will know how we are going to understand, how we are going to let the patients know, and what knowledge we have about HIV would be very, very important. This is also from Journal of Infection and Public Health, published in 2020. So now I will share my experience in Tawam Hospital. We have almost 300 patients. So 98% of the patients are on ART, and the 2% or 3% of the people who are not on ART, they have a severe problem or severe metabolic syndrome or severe intolerance to ART. So we have tried multiple ARTs on those patients, but unfortunately they did not tolerate any of them. Like somebody has a high liver enzyme, somebody has a heart problem, somebody has a renal problem. So in those patients, unfortunately, we could not give them antiretroviral therapy. Approximately 93% of the patients were compliant. So our community who are on ART, they are pretty much compliant actually. They come when even we don't have a clinic. They ask for a refill if there are one or two medicine left or the medicines are finished. So when they come, we usually don't refuse them, even if we don't have a clinic. If you're sitting in the office and they come and then we see their record and then we can refill their medications. Usually they have 2-3 refills, but if they don't have a refill, then probably we will give them a refill and ask them that they can come in a month or 2 months' time with the laboratory data if it's not been done. And approximately 85% of the patients do their regular labs. So this is very important to see because these medications are quite nephrotoxic, liver toxic, heart toxic. Fortunately, these days we have a good medications that have a minimal effect on all these: bone effect, bone density, kidney, heart, liver. We know all these things. But fortunately, currently we don't have those medications that are very toxic. They are, is in the past. So, but we need to know that few countries are still have those kind of medications that affects several systems. So we need to be careful and do regular labs. I think we'll listen to further lectures that how frequently we need to do CD4 viral load and other labs. 75% of the patient population show up in their scheduled appointments. So this is very important. Also, we have a tracking system. If the patients who have HIV, if they don't show on XYZ date, then what we do, we have a nurse navigator. They will call them and they ask them that why you are not showing, is there anything we can help? Or sometimes even, I will tell you that how we do accommodate them in our clinics. And patients usually have 2 to 3 refills so that they can come and collect them without seeing a physician. So that becomes a little bit easier for them because they don't have to wait for a long time to see a physician. During COVID-19 pandemic, we introduced a service which is called teleconsultation. Over the phone, we register them and then we talk to them about how they are taking medications, regular, not regular, if the blood work is done or not done. And then, we try to ask them that if they are free in a couple of weeks, 2-3 weeks, if they have not done blood work for few months, they can do a blood work and then they can collect their medications, or the medications will be delivered to their home. Currently, we are almost back to normal. The patients are coming back. So almost 90% patients who were not coming due to COVID pandemic, they are coming back, and almost it's back to normal. So how about CDC globally have remarkable gains? So what CDC recommends? They globally, there have been remarkable gains across the HIV testing and treatment cascade since 2010. And at the end of 2019, 81% of patients living with HIV knew their HIV status, and more than 2/3, 67, on antiretroviral therapy. The goal is 95%. Equal estimated 25.4 million of the 38 million. So remember, this is like 25 million people out of 38 million with patients living with HIV. They are getting antiretroviral. So this is a big number actually. That has significantly increased. It is more than tripled than 2010. So 2020 and 2010, it's a triple number. So it is quite a good number. And what is the other gain for CDC? In treatment effectiveness, as well as increases in the number of people who have their status and their environment and on the treatment are reflected in fact of the viral load suppression level on all the patients by 18%. See, now the crux point of this is the people who are doing HIV viral load and those patients who were not virologically suppressed in 2014 or 2010, there are 20% increase in the patients who are virologically suppressed by 2020. So hopefully, inshallah, by 2025 or 2030, we'll be having more people in this. Now, just briefly, one or two slides about the COVID pandemic, how it affected HIV. The COVID-19 pandemic also could have an impact on viral load. Early modeling showed that a severe disruption in HIV treatment because the people could not come and collect the medications because everybody was so scared to come to the hospital that they might get a COVID infection that they were not able to come and collect. So some of the countries have reductions in medicine collection for almost 20%. So this is very significant. The people cannot miss if there are on once a day treatment for a couple of days, 3 days, 2 days, even 1 day is not acceptable. So 20% less in some areas, and there have been multiple reports of people living with HIV were not taking enough antiretroviral medications for lockdown for more than 60 days. So 60 days, there are some of the areas they were not taking for even 60 days. So this was quite significant and quite concerning. That's why we introduced in SEHA, in all SEHA, this was introduced telemedicine, a teleconsultation in which we used to ask the patient that, if you need medications, we can deliver at your home. The COVID-19 pandemic affected in HIV. So monthly data from June 2020, January to June, reported countries with the UN AIDS have shown a substantial decline in the numbers of people currently on treatment over the 6-month period. So there was a decline in this pandemic, and then now we are catching up. If we get the data now in 2022, hopefully, inshallah, it would be a better thing. So in summary, HIV is a global public health issue, so we all need to understand that it is not in one country or another, it is a universal kind of phenomenon that we are facing. The education is important. People living with HIV, AIDS in many countries don't get their ART treatment on time, because some people still believe that if the CD4 count is less than 200 or 300, probably they will get the treatment. So the education is the mainstay that we need to tell them at any CD4 count, according to the current recommendations, they need to take their ART. GCC area knowledge and support is relatively better, I would say, because we are trying our best to give them medications on time, and even though that I alluded earlier on, if they are not getting it, there is a nurse navigator and we have a teleconsultation service. It still need to work. That's very important. COVID-19 pandemic affected a smooth supply of ART, not only in GCC, in many countries, in developed countries, in the USA, UK, in Europe, everywhere it has affected. And follow-up is an important part of the treatment. So you need to tell the patient that these XYZ labs needs to be done because it's potentially toxic medications. And we need to see whether this HIV medication is working or not. The viral load is suppressed or not. The viral load, if you need to achieve 95, 95, 95, the viral load needs to be suppressed. Now, different hospitals, as I said, different regions have different kind of viral load suppression definitions. But in our region, in SEHA, it is usually less than 20. In African areas, it's less than 400. So we need to understand that the follow-up is important. The important thing is to tell the patient, educate the patient, take medications, and not to skip the medication and do their follow-up. Thank you, and I will take any questions.